Hello friends, welcome to Dentlect. I hope you got to see my previous video on basics of periodontology part 1. Now would be on periodontal surgery as part 2. Again, less than 15 minutes. So treatment in periodontal diseases starts with the basic treatment, and then if it doesn't work, then we move on to the periodontal surgeries. So what do we mean by basic periodontal treatments? Step 1, record the baseline indices. So if you can recollect from the part 1 perio video, we had mentioned about the BPE indices, and then we have mentioned about the classification of periodontal diseases. So first step is to record the baseline indices. The second step is to give the oral hygiene instructions to the patient, such as how to brush, how to floss, how to use the auxiliary aids. The third step is to do a complete and thorough cleaning and root surface debridement. And following this, it is elimination of plaque retentive factors. Once all these steps are done, you will monitor for 8 to 12 weeks following the treatment. So if the treatment has been successful, then you will go into something called as the supportive phase. This includes reinforcement of patient motivation and prevent the recurrence of disease. If the preventive measures are failing, then you will go into the second phase, which is the corrective phase. Our aim in the corrective phase is to eliminate the pathology or the periodontal pocket, create a tight epithelial attachment, and arrest the loss of or improve the alveolar bone. So what are the treatments under the corrective phase? It is nothing but further non-surgical treatment if required, periodontal access surgery, regenerative surgery, mucogingival surgery, gingivectomy along with antimicrobials. Do not get overwhelmed by the sound of these terminologies. Let's see each treatment one by one in detail. When the periodontist uses the term non-surgical periodontal treatment, it includes threefold. First is oral hygiene instructions, second is mechanical plug control, and third is chemical plug control. Under oral hygiene instructions, it is educating the patient, and that can be enhanced with visual demonstration using a disclosing agent. Under mechanical plug control, we have the use of toothbrushing, interdental cleaning such as dental floss, many interdental toothbrushes, and the latest that we use is water pick or water floss. And the chemical plug control includes 0.2% of mouthwash or gel and 0.12% of mouthwash, and it is taken at the rate of 10 ml, and it's rinsed for about 1 minute and used twice daily. When it comes to scaling, it can be done using hand instruments such as sickle, curette, and hoe, or ultrasonic scaling, which revolves at around 25,000 to 40,000 cycles per second. You all know that microorganisms play a major role in the pathogenesis of periodontal diseases. So prescribing antimicrobials along with the said periodontal treatment is better to aid in the healing process. So we can broadly classify into systemic antimicrobials and local delivery of medicaments. So when it comes to systemic antimicrobials, it is specific for specific conditions. For example, when it comes to the treatment of periodontal abscess, you'll have to drain the abscess followed by a prescription of amoxicillin and metronidazole to act on the broad spectrum and the gram-negative bacteria. When it comes to necrotizing periodontal diseases, you will have to first identify the risk factor, remove the risk factor, followed by a good thorough scaling and a prescription of metronidazole. This has to be complemented with an oxidizing mouthwash such as 6% hydrogen peroxide. For the treatment of aggressive periodontitis, which is not necessarily related to the presence of plaque and calculus, you will have to start with a complete scaling and root surface debridement along with the prescription of amoxicillin and metronidazole for 7 to 10 days, 3 times a day. For the treatment of chronic periodontitis, it includes scaling and root surface debridement along with the prescription of tetracycline. There is an important non-antibiotic property of tetracycline that you must know. It basically reduces the host and neutrophil collagenase and also reduces the bone loss and increases the gingival gravicular fluid, the basic reason for this prescription. The next, moving on to the local delivery of medicaments. This is essentially available in the form of injected paste, gel, or impregnated fibers, just like your gingival retraction cords. And it helps in increasing the local dose and thus reducing the systemic uptake of these antimicrobials. The following forms are available: minocycline gel, metronidazole gel, chlorhexidine, doxycycline gel of 20%. The famous brands that are available are Periochip and Periostat. Now that you've tried all the non-surgical treatments and it is not very effective, from the supportive phase you move over to the corrective phase, which is the periodontal surgery. So the indications are as follows. 1. Impaired access for scaling and root planing. 2. Impaired access for patient's ability for plaque control. 3. Restorative driven surgery. 4. Aesthetic improvement is required. And finally, for implant related treatment. However, the contraindications for periodontal surgeries are poor plaque control, systemic diseases such as uncontrolled diabetes mellitus, severe cardiovascular problem, or bleeding disorder. Patients who are chronic smokers and teeth with long-term poor prognosis are also contraindicated for periodontal surgery. When we use the term gingivectomy, try to split these words. Gingiva ectomy. So I am trying to cut off of a portion of gingiva. So the following are the indications: deep suprabony pocket, reshaping of abnormal gingival contours such as in gingival enlargement conditions or gingival hyperplasia. However, there are certain limitations in this procedure, such as the zone of attached gingiva is not preserved and there is no access for infrabony defect or furcation, and the healing happens by secondary intention and it requires a long-term periodontal dressing. So let's see the procedure, how it's done here. Initially, you will do a pocket delineation using the pocket marking forceps, and then at an angle of 100 and 110 degrees using a crane Kaplan blade, you make an incision along the gingival margin, and then you will reflect the flap and you will cut off the excess. You will do a thorough root surface curettage and debridement. Once that's done, to promote healing, you will place a periodontal pack for the healing to take place. Next type of surgery is the flap surgery, and this is completely opposite of gingivectomy, and the advantages are as follows. 1. Zone of attached gingiva is preserved. The access to infrabony pocket or defect is obtained. Healing happens by primary impression and the flap can be repositioned coronal, apical and lateral. Exactly what a mucogingival surgery could not achieve, it can be achieved through flap surgery. There are several flap procedures and several techniques, of which two are very significant in periodontology. The first one is modified Widman flap, where the incision is made 0.5 to 1 mm from the gingival margin parallel to the long axis of the tooth, and two further incisions in order to separate the soft tissue collar from the tooth and the bone. And the healing occurs by long junctional epithelium, as you can see here in the first picture. The second is the apically repositioned flap, where you will do a reverse bevel incision on the attached gingiva, and there is a vertical relieving incision on either side, and the pocket epithelium along with the granulation tissue is removed with a curette, and the flap is displaced apically and then it's sutured. So these are the two commonly used flaps in periodontology. I'm sure by now that you know that periodontal ligament also involves alveolar bone. So any alveolar bone related pathologies needs bone recontouring, and the bone recontouring can be done either through osteoplasty or osteotomy. The terminologies have subtle differences. So osteoplasty means conservative recontouring of bone margin and that which is not supporting. And osteotomy is complete excision of bone in order to eliminate infraalveolar bone pocket, and also it reduces the alveolar support. So now you learned about gingivectomy and flap surgery. Now let's see about the mucogingival surgery, the surgery which is commonly used to treat gingival recession. The first one is through the free-form graft, that is they take a piece of tissue from the palate and then stitch it up to the area of the recession. The second is the pedicle graft or a flap surgery, essentially what I just described before, where you use a repositioning of the flap from the adjacent mucogingiva. So that can be either laterally repositioned, coronally repositioned, or a double papilla flap. Moving on to the next surgery, which is the crown lengthening surgery. This is something which the restorative dentists, the prosthetists, they always want to do before giving a good quality crown without violating the biological width. So the major indications and aesthetic concerns for using or prescribing a crown lengthening surgery is that helping in alteration in the soft tissue contour, debulking of hyperplastic papilla, which we call the gummy smile, the change in the clinical crown height, essentially for giving good crowns, harmonizing the gingival symmetry, reduction in excessive gingival display, again the gummy smile. The functional indications of this procedure are that to facilitate intracoronal and extracoronal restorations and to provide access to restorative margins, they are talking about the finish line, and increase the clinical crown height and the retentive potential. So when it comes to crown lengthening surgery, the commonly used procedures are gingivectomy, which I just discussed with you, periodontal flap surgery, and non-surgical techniques. So the gingivectomy can be done either with an external bevel format or an internal bevel, and periodontal flap surgery includes replaced flap, apically repositioned flap, or osseous recontouring. When it comes to the non-surgical techniques, it can be done through electrosurgery, laser, or CTT rotary. GTR, guided tissue regeneration, the most favorite topic of any periodontologist, because this is the one which has been saving them a lot during the perio surgeries. Why? Epithelium tends to migrate along the root surface before any cell type after a perio surgery, and this ends up giving them a long junctional epithelium, which in turn prevents any new attachment, so there is no regeneration into cementum, periodontal ligament, and bone. So GTR essentially helps them to form a barrier to epithelial migration long before the completion of periodontal treatment. So this helps them to generate the various tissues of cementum, periodontal ligament, and bone, giving them a successful outcome. So let's see the indications of the use of GTR, which is 2-wall defect, 3-wall defect, and furcation involvement. And please note, grade 1 furcation tends to have a better prognosis than grade 2, and grade 2 has a better prognosis than grade 3. Just like your sutures, GTR is either available as resorbable or non-resorbable in the market. And the ones in the major advantage of resorbable, or why periodontologists prefer resorbable GTR, is that it eliminates the need for the second stage surgery where you'll have to go inside, traumatize, and then again remove the GTR. And it is available in the common form of BioGuide in the market. It varies from country to country. Next is about bone graft. Say there is severe bone loss and you'll have to keep some artificial bone chips. That's what the general dentists understand this as. So you have various types of bone graft materials. The first one is autogenous bone graft, where it is taken from the patient's own self, perhaps from the iliac crest. And then you have the allograft, which is demineralized freeze-dried bone, commercially available. And then you have xenograft, which is taken from a bovine bone matrix. The most famous brand is BioOss. And then you have synthetic bone substitutes, and this is what is currently preferred by all periodontologists, which is perio class. Moving on to enamel matrix derivatives, famously called as EMD. The usage of EMD has its cultural restrictions because it's porcine derived, and it is a composed of propylene glycol alginate gel, and it acts basically on the Hartwig's epithelial root sheath along the root surface in order to induce acellular cementum. So for the steps for applying the EMD is just to open the flap, clean the root, apply some EDTA to increase the surface texture, and then apply a layer of EMD and suture the flap back. So this is not very frequently used because of the cultural restrictions, but otherwise it is a very good option. When it comes to the treatment of furcation, we have scaling and root planing. This cannot be skipped, so that's the first step. And unless the post-treatment morphology can be kept clean by the patient, these procedures, which I'm going to suggest now, will not be successful. So the first one is furcationplasty, where you will open the flap, do a thorough scaling and root planing, remove a portion of tooth in the furcation area, widen the access for cleaning, reposition the flap, and then suture it up. Apart from this furcationplasty, you have a technique called as a tunnel preparation, where the entire furcation is exposed and the flaps are sutured together intraradicularly. And then you have root resection, not very frequently performed, because you'll have to cut one or two roots and then do a root canal for the remaining root. It's a bit technique sensitive. And same goes for hemisection, where the tooth is divided into half, and if nothing works, all that we can do is extraction. So folks, that's a synopsis of periodontal surgeries, as short as I could make. And do comment yes if you want more detailed videos on any specific periodontal topics or any other subject for that matter. Do let me know your views on this. Hope this helps. Thank you. Bye bye.